Hello, my name is Gudrun Kunst. I'm a consultant anaesthetist in South London and professor of cardiovascular anesthesia. I would like to talk about the interdisciplinary European Cardiopulmonary Bypass Guidelines 2024. The publications are back-to-back in the British Journal of Anesthesia, the European Journal of Cardiothoracic Surgery, and in Interdisciplinary Cardiovascular and Thoracic Surgery. The table of contents of these guidelines is comprehensive, with 160 recommendations regarding perfusion, surgery, and anesthetic aspects of cardiopulmonary bypass. In this short podcast, I would like to focus on recommendations about perfusionist training, hemodynamic and cerebral monitoring, and organ protection. But first of all, some general information about these cardiopulmonary bypass guidelines. This is the guidelines task force team with an excellent spread of expertise, interdisciplinarity, and geography. Plus, there were 18 interdisciplinary reviewers from across the globe. Task force and reviewers have done tremendous work, so it was a real team effort. But with the publication of the guidelines, the discussion will and should continue, as best evidence is always in a continuous flow. Why do we need evidence-based guidelines? Apart from helping in clinical decision-making and standardizing clinical practice, guidelines identify knowledge gaps for future research, and eventually, as relevant outcomes are considered in the recommendations, these guidelines will benefit our patients. There are 160 recommendations in this guidelines document, with over half of them as strong recommendation, and that includes Class 1 recommendations, 44%, and Class 3, it is not recommended, 9%. What about the levels of evidence? The highest level of evidence, level A, was 9% in these guidelines, and level B, which included randomized controlled trials or large observational studies, was represented in half of the recommendation. This brings me to the first topic that I would like to cover, which is perfusionist training. The cardiopulmonary bypass guidelines have a Class 1 recommendation about the training of perfusionists. It is recommended that perfusionists complete a formal training period in an educational training program accredited by the European Board of Cardiovascular Perfusion and/or national authorities. Now, how is this implemented? We conducted a European survey in collaboration with the European Board of Cardiovascular Perfusion in 2023, and we included 211 centers from 34 countries. And the results revealed that in up to 15% of centers, there's still on-the-job training without a national recognized specialist qualification. The cardiopulmonary bypass guidelines also recommend that perfusionists need to successfully complete an examination of skills and knowledge as a Class 1 recommendation. And the survey results showed that a formal assessment of skills and knowledge for the certification of perfusionists is only conducted in 62% of European centers, with the national accreditation in 30%, and with international accreditation, for example, by the European Board of Cardiovascular Perfusion, in about half of the centers. What about cardiovascular monitoring recommendations in these guidelines, in particular transesophageal echocardiography? The usage of transesophageal echo is now a Class 1 recommendation. This was a Class 2A recommendation in the previous guidelines from 5 years ago. And this is because during the last years there were several publications demonstrating an association of improved patient outcomes with the use of transesophageal echo. For example, in this large North American retrospective multicenter study in patients undergoing open cardiac valve or proximal aortic surgery, the intraoperative use of transesophageal echo was significantly associated with a lower 30-day mortality rate compared with no usage of transesophageal echo, and a lower incidence of stroke or 30-day mortality. Also in patients undergoing CABG, coronary artery bypass graft surgery, 2 large retrospective studies were conducted during the last years, and they demonstrated an association between the usage of transesophageal echo and lower mortality, particularly in higher risk patients. And these studies all suggest that the risk of harm of transesophageal echo is outweighed by the benefit for our patients. Regarding near-infrared spectroscopy, there are 2 recommendations in the guidelines. The first indicates that near-infrared spectroscopy should be considered to detect cerebral hypoperfusion of any origin. And the second is a strong recommendation saying that during aortic arch surgery, neuromonitoring with bilateral NIRS, near-infrared spectroscopy, is recommended. So do we use NIRS in clinical practice? In the European EACTA-IC survey, we demonstrated that cerebral oximetry is used overall in 27% of cases, and in more than half, and 61% in aortic arch surgery, where cerebral perfusion and oxygenation are particularly vulnerable. And on the right side of this slide, you see that in acute aortic dissection national audit in the UK, which was conducted by ACTAC, the Association of Cardiothoracic Anesthesia and Critical Care, we demonstrated that cerebral oximetry is used in 84% of patients. And this brings me to the last topic. What about volatile anesthetics versus propofol and myocardial protection? This is now a Class 2B recommendation that volatile anesthetics may be used during cardiopulmonary bypass, and this recommendation is based on the inconclusive results from recent meta-analysis, which are summarized here. One which included on-pump cases, which demonstrated a reduced mortality with volatile anesthetics, and the other, including on-pump plus off-pump cases, showed no difference in 1-year mortality, however shorter ICU and hospital stays with volatile anesthetics. And this is a summary of 2 more meta-analyses in more general surgical and critical care patients, including subgroups of cardiac surgical patients. One meta-analysis by Kotani and colleagues demonstrated increased mortality with the usage of propofol, and the other no difference in mortality. So again, the results are inconclusive, and this is also reflected in the usage of volatile anesthetics in cardiac anesthesia. In the European survey, which we conducted, about half of the centers used propofol, and the other half used volatile anesthetics, plus with or without propofol. So this brings me to my last slides, to the conclusions. The overall aim of the European Interdisciplinary Cardiopulmonary Bypass Clinical Guidelines is to improve clinical outcomes of patients. There's a gap of formal training in up to 20% of the centers, cardiac centers in Europe, and perfusionists in these centers are still trained on the job. Intraoperative transesophageal echocardiography is recommended as a Class 1 recommendation. Usage of near infrared cerebral oximetry is a class 2A recommendation to detect cerebral hypoperfusion during cardiopulmonary bypass, and a class 1 recommendation in aortic arch surgery. And clinical outcome results regarding the usage of volatile anesthetics are still inconclusive. Thank you for listening, and please do get in touch if you have any discussion points or comments. And you can find my email contact here on this slide. Thanks again. Thank you.